welcome listeners and viewers back to the Eyecare Experts. I'm Dr. Bell, Dr. Terrezza, and we have with us Dr. Johnson today. So thank you for joining us, Dr. Johnson. And before we get into our topic of today, give them a little bit of background. You know, where'd you go to school, where you're from, that sort of thing.
Yeah. I'm from Fairhope, Alabama, born and raised. I just graduated from UAB School of Optometry back in May, just a few months ago. So I'm excited to be here working with these guys, good people to learn from. Yeah.
She said she just graduated, right? So well, I can assume they've got a little bit more advanced equipment than we had going back there in the days.
Oh, they're much. She's on the edge of the cane.
That's right. You know, when I was in school, the OCT was just coming on the scene. We had the HRT and the GDX, and the OCT was just coming out. So it's a different ball game nowadays.
When I was at Alabama, the visual field was just coming out.
Gosh. Well, let's get back to the topic of the day. This may not be the sexiest topic, but I tell you, it is one of the most widespread, especially in our field. And we're talking about dry eyes. It affects, it really doesn't matter how old you are, environmental conditions, certainly autoimmune things. There's so many things staring at the computer screen. There's a lot of things that feed into this. And then some people know that, don't know they have it, or they will come in with certain complaints and say, hey, I have this or have that, and not necessarily think or relate it to dryness or dry eyes. But let's start just basically with either one of you want to jump in. What is your definition of dry eyes? When a patient asks you, hey, what is dry eye syndrome or what is dry eyes, what would you say to them?
Dr. T?
Well, I got to think a minute. I try to talk in rigorous terms, but in this case, I will tell you that it's a general condition that has multiple etiologies, and it's a very difficult thing to diagnose, and it's characterized by many symptoms. So it can come from, there's different forms of it. Basically, the patient will complain that there's sandy or gritty feeling in the eye, or have difficulty with their vision blurring, or those are the two big ones that come to mind. Or they say that their vision fluctuates a lot during the day. And you would think that would be due to other causes, which it might be. But certainly changes in the tear film can cause those kind of symptoms. So in terms of a rigorous definition, I guess the eye is the only part of the body that breathes for itself. It takes in oxygen and blows out carbon dioxide, and it breathes through the tear film. And if you don't have enough of those tears, that's what defines a dry eye.
What do you think? What do you experience, or what do you hear, I guess, in clinic?
Yeah. Some of the common things that I hear patients complain of with dry eye that they typically don't relate to dry eye are burning, itching, redness, watery eye, fluctuating vision, the gritty foreign body sensation. And I'd like to say, too, that dry eye is a chronic condition. So there really is no healing dry eye. It's more so about treating the symptoms and helping with comfort after you've established that there is dry eye.
Well, I think one of the, there's a bunch of what you said there, but one of the things that I hold is when you say tearing a lot, because patients will come in and they'll say, hey, my eyes are tearing a lot, or, and they don't necessarily think, hey, how can they be dry if they're tearing a lot? And not realize that maybe the reason they're tearing so much is the body's trying to help you out to try to help with that tear film so the surface of the cornea isn't as dry. So they don't sometimes relate those two things with dryness and tearing. But, certainly it could be evaporative condition. It could be an aqueous deficiency issue. Nowadays, it seems like everybody's on the computer, on the cell phones, where they're staring at the screens, which typically affects the blink rate. Certainly air conditioning, especially in Florida. The air conditioners, especially as we're warming up here, are going to be running nonstop. With aging, there's so many things that factor into that. Certainly, sometimes when we blink, we don't do a full blink. Sometimes we have entropions, ectropions with the eyelids where they don't necessarily smooth the tear film like they should. Lipid, we have meibomian gland dysfunction, things where it's not coating the tear film like it should. Why don't you go through, you always kind of usually talk about the different layers of the cornea, and that would be probably.
Yeah, I think the three basic layers, if you could, well, there's many layers, and it reminds me of the book by Dr. Holly, PhD from the University of Texas, who wrote a 3-volume book, which I had to read at the University of Alabama, the biochemistry of the human tear film. And the numbers, they haven't even, back in my day, they had stopped the number at 115 to include proteins and mucopolysaccharides. That number has since gone up, and the complexity in their interaction has also gone up. So the eye has to breathe for itself, and it breathes oxygen through water, and if the water level isn't correct, a lot of things physiologically get out of whack. And it's very important to keep that as constant and as full as it could. There's an oil layer on the top to stop the water from evaporating. There's a mucus layer underneath. They argue about the value of that, and basically it's a lubricant on the eye, and sort of like grease on a ball bearing, but that's one of my Milton explanations. Yeah. And I'm not sure if that holds water, no pun intended.
Across the board.
Yeah. But those are the layers basically you have to keep intact. And if the water layer is not proper, the oil mixes with the mucus layer, and that produces semi-colloidal substances that tend to collect. People refer to that as sleep in the morning. And those glands that produce that oil, that's what Dr. Bell was referring to as meibomian glands. And they can get clogged up, distorted, non-functional, bacterially infested, mite infested. Gosh, there's all kinds of things.
Yeah, there's one thing we haven't covered is autoimmune. I mean, I think in the world as a whole, more people are becoming, autoimmune conditions. We can debate why that is, but certainly, whether it's Sjogren's, whether it's rheumatoid arthritis, a lot of these autoimmune issues will cause chronic issues with the tear film and the dryness, and that certainly factors into this. And certainly the old days, I know in the old days, umpteenth years ago, we'd say, hey, here's a tear, or go get you a pair of, get you this artificial tear. And it really, it may feel better, but it's not really solving the condition, if you will. And so nowadays, we need to figure out why the eye's dry. To your point, is it because of the glands? Is it because which layer of the tear film is affected? Because if we can't figure out what the cause is, we really can't help to cure you. And there may not be a cure that you use for a week and then stop altogether, but certainly we can, once we pinpoint why you're having the issue, we can certainly treat you better. Your symptoms will be better, because this can go from mild to severe. I mean, there's some patients who, that are deathly affected where it affects their vision, where they're trying to put tears in, every hour throughout the day. And then not to even talk about surgeries. But nowadays, if a patient's going to have like a cataract surgery or LASIK surgery, these are things that all surgeons want to have addressed prior to the surgery, because it's a better outcome if we help the tear film, we help the dryness and all that prior to even having a surgery. Is that what you see? Or
Absolutely.
Yeah.
I think dryness, even after having LASIK or cataract surgery too, is super common, especially with LASIK, and their method of performing that procedure will disrupt the corneal nerves that kind of sense any irritation on the front of the eye, and will help stimulate the production of more tears too. So dry eye kind of goes in lots of different directions.
I think the complexity of the field could be indicated by the fact that in the last 3 to 5 years, there are now 13 medications with completely different mechanisms of action to treat dry eye with. And so it gets very confusing, and patients get frustrated that this drop didn't work or that drop didn't work, or that mechanical procedures, which have now become widespread in terms of intensity pulse light treatments, in terms of punctal plugs where the tear ducts are plugged as an effort to keep tears in the eye, and
Did you talk about LipiFlow?
No, I didn't. And pressing the glands via a procedure called LipiFlow, which is a mechanism which we have at the office, but has since it's sort of peaked, and other things are taking its place now as technology develops on this problem, because it's become so complex and so multifaceted. it's very hard to get a handle on it.
Well, thing to note here, I think in general, is we treat all these. I mean, we offer punctal plugs, we have LipiFlow, we have, we can prescribe any of the prescription medications to help you with dry eyes, to help with tear production, all those things. So certainly come in to see us. If you have any of these symptoms that we talked about, red eyes, they're burning, they're sandy, they're gritty, you're having to blink a lot, your vision goes blurry, and then clears up, minutes later after you blink. There's a lot of things, a lot of symptoms. If you have those, come in. We can see you for a full exam, or we can see you just for an office visit, which we see patients all the time, because usually dryness varies. I mean, it can get worse throughout the year, get worse, depending on what you're doing in your life, and we certainly want to see these patients in the office and help them.
Another one I think we shouldn't gloss over is that all the symptoms can be a function of side effects of medications that have become so widespread now. The average patient averages between 5 and 10 medications per day. And some of the side effects of those medications can produce dry eye symptoms.
Well, I know for me, just going back, and I'd say the last probably 4 or 5 years, some of the probably the more severe cases that I had with dryness that had severe, what we call punctate keratitis. I mean, it was almost, the cornea was rupturing like an ulcer because it was so dry. And I'm thinking of one patient in particular where I fit her with amniotic membrane to kind of put over that surface to kind of give it a chance to kind of moisturize and to kind of heal some of that dryness because the exposure to the air was just drying it out so much. That's one particular case. But there's a lot of things that we can do. So if you're in this situation, don't think, hey, I've tried every over-the-counter artificial tear and it doesn't seem to help. Come in to see us because there's other things that certainly we can do. Yeah. You talked about IPL. That's a big one nowadays. I mean, certainly there's even some states out there that actually some of the optometrists are allowed to even do IPL on the lids and things like that.
About 14 states now, yes.
So hopefully we'll see what the future holds for the state of Florida, but I have some of my colleagues that have had really good results certainly using it. So we'll see what happens. Alabama, maybe. We'll see what happens in Florida.
We should know this year.
Yeah. So again, this may not be the sexiest topic to talk about, but it definitely affects a lot of us. And a lot of things I see, patients will come in and maybe it starts with dryness and then maybe they get allergies on top of that or they get something else, but it tends to make everything a little bit worse. And sometimes patients will come in and they'll say, hey, my eyes don't really hurt me. But it may be so bad that the cornea is so, I don't know what the right word is, but it's just, we talk about it where it just doesn't have the feeling, it's desensitized because it's been dry for so long that patients don't even realize how bad it is. We've talked about that in the past as far as like neurotrophic keratitis and things like that, where we look in the slit lamp and we're like, hey, this doesn't look that bad to you, but this is a pretty bad condition.
Speaking of that, there's a new drug for that, which we've tried in office and done very well with by Dompé Pharmaceuticals. So even when you get those drastic cases, there's drugs now for some of that.
Well, one of my favorite things you talk about, and we've talked about this before, moms come in, patients come in, and they say, hey, my kid's on the computer all day long. How often should he take a break? Can he be on there for 2 hours? Is that a problem? What do you recommend as far as time on, time taking a break, at least on the computer? What would you say?
What do you think?
Either one of y'all say.
20-20-20 rule. Every 20 seconds, take a 20-minute break. Can I start?
You can
No, go ahead. Just flip that around. So,
Yes.
so every 20
minutes,
minutes,
take a 20-second break and look 20 feet away. And just remember to blink and give your eyes a minute to kind of readjust, relubricate everything, let the tear film spread around again, and things should improve.
Yeah, I mean, I always say even if you're reading a book, I think that's different than looking at an actual computer screen because of the pixels and the refresh rate, the way your visual system is made, you just tend not to blink. You tend to just stare at that screen, and that's what causes dryness, computer vision syndrome, fatigue. There's a lot of things that certainly are affected by that. But, we talk about drops. We talked about a lot of prescription medications, but let's talk about, omega-3s. Omega-3s, fatty fish oil, eating fish. Heck, we're in the panhandle of Florida. There's other things that you can do that help, with that tear film and help with the surface and the dryness in the cornea.
It's amazing to me the variation that I get. Some patients, when I tell them to follow those procedures, they do very well, and others it has no effect at all. So again, it makes this complex, and it takes a while to figure this out.
I know, and I may be different from you on this, but one of the things I usually ask is I'll ask patients, hey, is it better, is it worse, I guess I should say, in the morning time or the afternoon? Do you feel like when you wake up, is that when you're having most of your symptoms, or do you feel like as the day goes on, it becomes more of an issue? Because for me, that helps me to know, because sometimes it's nighttime related. As you're sleeping, maybe you're not closing those lids all the way. Maybe there's a ceiling fan or a vent that's blowing on you. Maybe it's a CPAP machine, something like that, that's kind of getting you, or is it something as the day gets worse? So those are things that certainly, we want to find out. I know in general with the issues we had with some of the tears, it's been probably about 9 or 12 months, but I know some of the patients that I have are still hesitant about using drops. So come in. If there's a question, we want to make sure we get you the right medication and, get you something that's going to work for you.
Well, they should know this too. I guess this is as good a way to advertise this as any, that there's a national lawsuit against generic over-the-counter drugs, and it involves all the major pharmacies, CVS, Walgreens, Walmart, and that'll be 2 to 3 years till it reaches its conclusion. But for now, I'm advising patients not to use no-name generics. For Dollar Tree and Family Dollar, all those are included. And there have been some, there wouldn't be a national lawsuit if there wasn't a problem with that. So I tell them to use name brand on that I make specific recommendations, but if they're going to get it on their own, then to stick to name brand.
Yeah, I think that's that's a really good recommendation. But certainly, give us a call, come in. We want to help you. Any more thoughts before we wrap up? Anything else you can think of we didn't cover, or any other advice?
I think Dr. T made a great point that the same treatment does not work for everybody. There's different types of dry eye, and we need to target those symptoms in different ways. Even if it's just an over-the-counter artificial tear, different artificial tears work for different people, whether it's the preservative in them or the vehicle. People situation to get
with dryness and dry eyes, especially the moderate to severe cases, sometimes it's not going to heal up in 5 days or 7 days. And some of these medications, the prescription ones, it takes even 3, 4, 5, 6 weeks to get max results from that medication. So it is a commitment. So I guess I would say just to some patients, we want to get you better, but sometimes don't judge it in 2 days or 5 days or 7 days, because sometimes it takes weeks and weeks for these medications to kick in where you're actually getting the results that we need. But we appreciate you listening. Certainly, like us on the podcast, ask us for any questions, any topics you want us to cover in the future. Thank you, Dr. Terrezza. Thank you, Dr. Johnson. But we appreciate y'all listening in, and stay tuned. Thank you.